Thanks for joining the session. This is Responding to the Infodemic in Congo DRC. Experiences from Ebola, Polio, and COVID. Brought to you by Ghaffar and Karen. Ghaffar and I both work for UNICEF in DRC, and we have together many years of experience working on Ebola. Ghaffar was in West Africa before coming to Congo, working on the Equateur outbreak 2018, outbreak in the East, and then the new Equateur outbreak, 2020. Myself, I joined the Ebola team in the East in 2019, and before that worked in polio. Ghaffar also worked quite a bit in polio, both in DRC and elsewhere, and this is our attempt to show you how credible we are. Did it work? All right, let's go to the roadmap for our session. 4, 3, 2, 1. We're trying to make it short and keep your attention. So we'll talk about 4 lines to set the stage. We have 3 maps for context about Congo, 2 key questions, and 1 failure. Why not? Let's be honest. Sometimes we can learn more from failure than we can from success. So these 4 lines, this is a quote that we really liked from the Infodemic Management News Flash number 2 by WHO. It says an infodemic is an overabundance of information, some accurate, some not, that spreads alongside a disease outbreak. Infodemics are nothing new, but in the digital age, they spread in real time and create a breeding ground for uncertainty. We're sure you can relate to this idea of too much information. We know this course is a lot of information as well, and we're just adding to the problem, to be honest. Starting with this first map, which is it's just showing how many disease outbreaks are happening. This is actually from 2017, but the updated map that we found wasn't much different and didn't look as good, to be honest. So this map is simply showing that Congo DRC is in the middle of a region where there are a lot of problems. And this next map is showing that while Congo has had a lot of Ebola outbreaks, there have been other Ebola outbreaks in other countries. So we're not the only ones fighting this problem, but possibly the only ones fighting it consistently since 1976. I'm sure at some point, if it hasn't already happened, we'll stop talking about outbreaks and start talking about endemic. And this last map shows, we wanted to include this because it's featuring the Equateur province, which is where we have a current outbreak. And this map is actually from the 2 outbreaks ago, but it's from a partner that we really enjoy working with, Translators Without Borders. And they've taken the time to show different language groups within the area, and their work is really useful. And it also reminds us that, that infodemics are hard, but imagine infodemics in so many different languages, and I'm sure many of you face that in the places that you work. On the left, you can see the 11 outbreaks in DRC for Ebola, and you can see the number of cases reported and the number of deaths, and frankly, it's been really trying on the health system, as you can imagine, and many of you may have worked in West Africa during the Ebola outbreak there, so I think you're probably aware of what repeated outbreaks can do on the health system. Okay, let's jump straight into the first of our 2 key questions. And these key questions are really there to help establish some concepts and some vocabulary as you move forward in the course. We made an effort to not cover material that we knew you had already seen with previous speakers, also not cover material that is simply Googleable, and we just wanted to focus and help set you up for the future presenters and future sessions. This key question is, can we solve the problem at our level? And this is a question anyone can ask because different people will be at different levels. Some people might be at the tip of the spear, out in a remote area. Some people might be sitting at a major city at a coordination table. Still others might be at headquarters. So, this is a dashboard tracking rumors, courtesy of our amazing colleagues at the Red Cross Congo and the International Federation of Red Cross Red Crescent, who collaborated with OCHA on this humanitarian data exchange dashboard, with analysis help also from CDC Atlanta. So this is an incredible collaborative effort, and I chose this screenshot because it shows that the number one rumor for many weeks in a row in Beni during the Ebola outbreak was that Ebola is a plot of the government. And this is something that is historic. It comes from 30 years of neglect and conflict, and it's simply something that may not be able to be addressed. So this is a problem that may go beyond, your team of infodemic managers, if that such a thing exists, or your immediate, the people that you're working with immediately. Some problems are just bigger than us. And to make this point even stand out a bit more, we'll share that we had so many resources and continue to have a lot of resources in addressing the Ebola outbreaks in Congo. But as I mentioned, some of them are just not at our level. They're at a political level and not at a coordination or operational level. And on the left, you can see a list of different things that we used, and you'll hear a lot more about many of these in some of your key speaker sessions. So we're not going into too much detail. Fact checking, for example, we know will be covered. We had social listening from Novetta, PALM, and the International, so the Institute for National de Recherche, so INRB in here in Congo. We had rapid intervention teams, which were incredible for putting out fires before they got too big in terms of community unrest, and because there was quite a lot of unrest, and some of it did come from misinformation, some of it came from other sources, but our rapid intervention team of leaders was really good at putting out those fires. We had rumor bulletins from Internews, perception trackers, Mercy Corps, and I think Oxfam was contributing to that. We have a social science analysis cell that produced, I think, 57 studies in the span of 18 months. So it really wasn't a problem necessarily of lacking resources. During this most recent Ebola outbreak, we did what we call feedback on the radio, bringing community concerns to our radio partners and having government experts respond to questions which we had already pulled out from community feedback, but also responding to questions that people would call in or send in by SMS. And then during COVID, we had this toll-free call center, which we get anywhere between 6,000 to 15,000 calls per week that are completed. This doesn't include the ones that hang up or get tired of waiting. So we have a lot of resources, and they're just simply things that can't be solved at our level. And here's an example of one of those issues that was beyond our control. And this is, you can see here a social listening report from Novetta that relates to the new vaccine that was introduced. This was a decision that was made at a higher level. It was very complicated. It was all in the name of science, but anytime you introduce a new vaccine, not to mention a second vaccine, you can imagine, people, why do we need a second vaccine? Is the first vaccine not working, etc. So it caused a lot of communication pressure, and we were not able to solve it all. And these decisions were outside of the scope of what we could control. We mentioned that we would talk about polio. So here's an example from Pakistan, and First Draft, who's helping to organize this training, put together a fantastic article. I was in the heat of things in Pakistan and at headquarters for UNICEF in New York, and this was an issue we were tracking really closely. And they managed to capture so well with beautiful data visualizations what happened when somebody staged a fake news event, essentially, of children being sick from vaccine, which caused huge panic, which led to health centers being burned, which led to health workers being killed. So this is, again, an instance of a political act that leads to misinformation and that has fatal consequences. So we're hoping that these examples will serve as reminders to you when you're going about your work, and you'll ask yourself, okay, what kind of problem is this, and can I solve it at my level? And it doesn't mean you give up. You might simply need to escalate it and turn your communication powers upward instead of outward, and work on decision makers and leaders in order to get maybe new decisions, new policies, higher level risk communication. For this first key question, we'll stop with this reflection, a couple quotes. Jean-Jacques Muyembe is one of the people who worked on Ebola way back in 1976. He's an icon here in Congo, and he mentioned in an article in The Lancet last year that community reluctance has been fueled by misinformation and speculations about the central government's involvement in the virus spreading to suppress an electorate favorable for opposition. There's a it just so happened that Ebola coincided with elections, so you can imagine it got politicized fast, and he's just acknowledging that in this quote. This one from Heidi Larson of the Vaccine Confidence Project, that rumors take root in the soil of doubt, and it's a soil that wants attention. We don't have a misinformation problem, she says, we have a trust problem. So as you're going about your work and you're thinking about what you can do at your level, if it really is a trust problem, you should think closely about where that trust should come from. And if it's not at your level, then find the level and try and work at that level through whatever powers of influence we're sure that you have as infodemic managers to be. This next question is related to the first. You might call it a subset. So it's, can we solve the problem at our level, and then can we solve the problem with communication? And the image on the left is showing people who are protesting because they haven't been paid. As it happens, this group of people actually should not have been paid because they had their contracts which had been ended, and they claimed to have continued working but without contracts, and then they went public with not being paid. But on the right, you can see Ebola business. These are concerns that people are talking about. And what we're saying here is simply that there are real issues that people complain about, and these can lead to misinformation, but they can also just lead to noise, and sometimes they're related to real problems, and those problems cannot always be addressed with communication. An example of this can come from community feedback, and we're just showing a slide here from one of the sub-coordinations in Ebola, and they've categorized feedback into different buckets. What kind of feedback is it? Is a complaint? Is a rumor? We've categorized it into different technical pillars to whom this feedback should be addressed, and the pie chart on the far right, you can see that half of the community feedback is actually being addressed to the coordination, which means that the analysis has suggested that there is a decision that needs to be made, an investment that needs to be made. So this isn't in the realm of just answering people's questions. Sometimes it's investing in real world resources. It could be a health center that's not functional. It could be a bridge to get to that health center. So while communication teams are often the ones that bring in the complaints and the misinformation, they're not always the ones that can do something about it. And one of the ways, this slide shows a simple operational tool that it could go overlooked, which is why we're mentioning it. And that's, we learned during our feedback multi-organization meetings, multi-technical pillars, that if you want people to show up, sometimes you have to name and show participation stats. And so we started tracking which organizations were participated, and we tracked also which technical pillars participated. And this was a way to ensure that people would come, because by coming to the meeting, they could help co-create action items rather than having a group of communicators say, hey, infection prevention control, you should do this, or surveillance, you should do that. So it's really key as you're analyzing data, in particular related to feedback from community members, whether it's coming in social media or it's coming from a Red Cross volunteer out in a town, that you look at this in a group that's larger than just communicators, and that those actions are decided jointly. It's a much greater chance of uptake if you do it that way. Again, wrapping up this key question with a quote. This comes from somebody you may already be familiar with, and somebody who worked on Ebola back in 1976 alongside Jean-Jacques Muyembe, Peter Piot. He says, we shouldn't forget that this is a disease of poverty, of dysfunctional health systems, and of distrust. So this word trust, you see it here again. It's just a helpful reminder to us, and as communicators, we may not be able to establish trust or correct historic wrongs or address years of neglect through our communication. So just keep that in mind as you move forward. Okay, let's get on to, we're wrapping up now. We're getting close to the end, and we wanted to keep this a little bit shorter because of this too much information problem. When we saw how many presentations you'd be following, we thought, okay, let's just say really the key essential things and not go on too long. So the failure, I think, as a system, as a group of many organizations, was that we did so much collection of data and we often weren't able to act on it. And I could have added here, not enough accountability to affected populations, but I'll just say it instead of writing it. And you can see this tool, normally, a data life cycle should be a circle. You collect data, you analyze it, you present it, you act or you don't act, but then you go back to communities and you explain why you've acted or why you haven't acted or what you've done. And that's a circle, but we put it in a line because often when we talk to people, and this is a tool that I had developed in polio on the same observation, so much data, not enough action, and basically put a line down the middle and said, we're focusing so much on the left side, on collecting and analyzing, and we're not putting enough emphasis on the right side, which is acting and adapting, documenting what we've done so that we could tell community members, hey, we increase the number of beds at this clinic because you said there weren't enough, or we put in this bridge so you could get to the clinic, or we weren't able to pave that road, hey, sorry, because it's beyond the scope of what we can do in a public health emergency. So just letting communities know with what you're doing, with what they're saying, is really key. This is getting a bit outside of the realm possibly of infodemic and what you might think of as addressing issues primarily on social media, rumors, misinformation. But it all gets bundled together when you're sitting in a feedback meeting, or you're listening to social science results. Sometimes, you're getting just community requests at the same time, which is why we're talking about the too much data, not enough action problem. I will say that it wasn't for lack of trying. We did some things like mapping what we call data itineraries, when they get the feedback, where does it go, and does it go to the right place, and are the decisions and actions being taken close enough to where the original comments came from. And this, of course, could be a rumor or misinformation, which is why keeping the loop really tight, keeping it close to the source is key. So we did a lot of analysis about how data was flowing and where action was happening. So we improved over time, but I'm calling it a failure, but I'm actually wrapping it in a bit of success because I wanted to talk about data. And while I do think we could have done more, I think we did quite a lot. This is a slide from a social science presentation, as I mentioned. A group of multidisciplinary people, UNICEF, WHO, Doctors Without Borders, CDC, a lot of people worked on social science during the Ebola outbreak, and sometimes we would learn things like frontline workers, they self-assess as having very minimal training or minimal knowledge, and sometimes we simply couldn't do a lot about some of what we learned, and that's for lack of resources, for lack of time, or for lack of focus, and needing to focus on hotspots instead of places where maybe the outbreak had already gone through and was no longer active. So, as you go about working in a public health emergency or an infodemic emergency, really think about the scope of what you can and can't do, as we mentioned, at your level with communication. And you're going to have to build some muscles and be able to explain to people why sometimes you're not able to act. And it's just an important way to manage expectations and to communicate about that. This slide is there to reinforce the previous one, this is one now that we did during COVID in July, a quick U-Report poll. U-Report's a digital engagement platform, and we asked people, what was your concern this week? And they said it's money, it's work primarily, it's confinement, it's schools being closed, and coronavirus came in third place only. And again, so how do you act on this? Are you able to convert this data into action? And sometimes the question is, why ask if you can't do anything about it? In this instance, we asked the question because we had a sense that even though we kept talking to people about corona, we just knew that they had other concerns, and some of those concerns were at a political decision level about confinement, about schools being closed, and what we were doing actually was advocating for a higher level of risk communication from the government side to speak more about policies. The public information or government communication function, we were advocating for a stronger presence in a range of places, media platforms, etc. So we did ask the question knowing that we might not be able to address it, but we were hoping to throw the hot potato to somebody else and have them address it, and we needed data to make the argument. So this is, but in the end, the reason we're showing this is to say that what you want to do is convert data into action, and decisions are a form of action, and this it doesn't always work, but you can obviously do your best. Like I said, sometimes your communication skills are turned upward. Sometimes we need behavior change for policymakers, and so let's use those skills in both directions, and not turn always and put the responsibility or the blame on community members, and think about those of us working in an outbreak response or the people making the decisions at the higher level as people who may need to have their behavior changed at times. This final slide is about some small successes in converting data to action. I think COVID really taught us to really get faster and to be more digital than we were in Ebola. And we also learned to get simpler and to not rely on glossy graphic design, posters or pamphlets, or even little, what I call shareable squares for social media. Sometimes it's just a word version of a conversation guide for traditional healers that we prototyped this, we used it live, we got input from traditional healers, we adapted it, we sent it out to the field. This is still during Ebola. We sent it in words so people could adapt the language. We had different language versions. They could improve on the Swahili if they needed to, or the Lingala. So word versions were, it's like the great innovation. But sometimes it takes confidence to go simple and trust in communities and people working further down the chain than you are, that they can take something and improve on it. On the left here, we're showing a little WhatsApp prototype that we created for the IFRC had aggregated all the feedback into the 25 most frequently asked questions, and that resulted in a 10-page document. And we tried doing a digital prototype, and people told us that actually we don't want it because it takes up too much of our data. So that was a humbling moment. But anyway, that was a great collaboration with IFRC, support from CDC, Translators Without Borders. The final photo is a photo of a co-creation session that we did with women, and we also learned that community members, of course, they have so much to say, and they might not be the medical experts, but they are the experts in communicating with people around them, and they know the right words and the right approaches. And so we did it late, but I'm proud that we did it, and we were better at getting community members involved at an earlier stage. Instead of a pre-test, hey, we've baked the bread. Do you like the bread? Do you want to put jam on it? It's like, let's come into the kitchen. Is it bread? Is it chapati? Is it something, completely different? Fufu, does it have to be bread? So by getting people involved earlier, we were able to improve our content, and this for us is a form of accountability to affected populations. It's not just responding to their complaints. It's also getting them involved. Yeah, so gosh, we're already at 25 minutes, and this went by really fast. The last slide has some resources, but we're going to get this presentation to you so that you can click on all these links. So we won't talk about them. You can explore if you have time. Good luck in the course. Thanks again for joining us, and good luck.